Today is Friday, September 29th, 2023 at 11:07 a.m. Arizona time. Welcome to a web briefing of the Arizona Advisory Committee to the U.S. Commission on Civil Rights. I'd like to remind everyone that this is a public meeting and it's being recorded. Present on today's call are staff of the commission and members of the Arizona Advisory Committee. There are also members of the public who will be invited to speak during the public comment period of today's briefing. My name is Leslie Ross, and I am the chair of the Arizona Advisory Committee. I will now take roll. Committee members, if you are joining by phone, please press *6 to unmute yourself and *6 to place yourself back on mute. Forgive me, I said I would take roll, but typically Christina does. Christina, would you like to take roll?
Sure thing. Thank you, Madam Chair. Leslie Ross.
Present.
Angela Banks.
Present.
Rebecca Browder. I believe we have Rebecca here.
Yeah, she's present.
Great, thank you.
Yeah, sorry about that.
No worries. Tessa Dysart.
Present.
Patty Ferguson-Bonny. David Kim.
Present.
Teresa Rassus. Emma Robbins. Jonathan Rose.
Present.
Beverly Traver. Heather Whiteman-Runson. Henry Whitmer.
I'm here.
Eric Yorty. And I believe we have Eric as well, yes?
Yes.
All right.
Yep, I'm here, sorry.
No problem. And then we have Kayla, and I believe Angelica is not yet on. And we do have, it looks like we do have some members of the public in addition to our panel presenters. I believe we have Amanda Hagerman. Is there anyone else who's a member of the public present? I think that's it. All right, roll is complete, Madam Chair. Thank you.
Thank you. We have a quorum present and we'll proceed with the meeting. Also present is Commission staff Kayla Fajoda, our DFO. Angelica, our support specialist, is not here yet. Before I invite our speakers to present, I want to give a brief background of the agency. The U.S. Commission on Civil Rights is an independent, bipartisan, non-enforcement agency of the federal government charged with studying discrimination or denial of equal protection of the laws because of race, color, religion, sex, age, disability, or national origin, or in the administration of justice. An advisory committee to the commission has been established in each of the 50 states and DC, as well as the 5 territories and commonwealths. They are made up of responsible persons who serve without compensation to advise the commission on relevant information concerning their respective states. The Arizona Advisory Committee voted to investigate the topic racial and ethnic disparities in pediatric healthcare in Arizona. Today is the second of several web briefings that the committee will hold throughout the next few months. Today, we will hear from Matt Jewett, Dr. Murray Feldstein, and Dr. Nathan Page in a moment. After the panelist presentations, advisory committee members will have an opportunity to ask questions of the panelists. This Q&A session is reserved for committee members only. After committee Q&A, there will be a public comment period where members of the public will be given an opportunity to share their perspective and opinions on the topic. If you're not able to share your full remarks today, please email your remarks to atrevino, TREVINO, @usccr.gov for inclusion in the committee's proceedings. The briefing will conclude after the public comment period around 1:45 Arizona time. The committee will then move into conducting committee business related to planning future briefings. If you are a panelist or a member of the public, you may choose to stay on the call if you wish, as all of the Arizona Advisory Committee members are open. Committee meetings are open to the public. Finally, I will go over some key ground rules for the briefing. I want to remind everyone again that this meeting is being recorded and will be transcribed for the public record. All attendees should mute themselves when not speaking to capture high-quality audio for the recording. To view closed captions for today's briefing, click the CC icon in the lower left corner of your screen. When recognized, go ahead and unmute your line, and note that if you're calling in, you will have to unmute by pressing *6. I ask that you please state your name when speaking to assist with transcription. Lastly, as the chair of today's meeting, I reserve the privilege to cut short any statements that may be important but irrelevant to today's topic. I may also cut short statements that defame or degrade a person or organization. Anyone or organization that feels it has been defamed or degraded can file written statements for inclusion in the proceedings. I urge all persons making presentations to be judicious in their statements and remain on topic. The Arizona Advisory Committee appreciates the willingness of all participants to share their views and experiences with the committee. As I mentioned, we will go into the panelist presentations portion of our meeting today. And today we will start with Matt Jewett, who is Director of Health Policy from the Children's Action Alliance. Dr. Murray Feldstein, he's a visiting fellow at the Goldwater Institute, and Dr. Nathan Page, who is with the Phoenix Children's Hospital. Typically, we would hear from all three panelists before moving to committee Q&A. However, due to a conflict that Matt Jewett has, because he will have to leave our meeting at noon, we will hear from Matt first, and then open the floor to committee members who might have questions for Mr. Jewett. And then we will return back to Dr. Feldstein's presentation no later than around 11:50 a.m., excuse me. Okay. With that, Mr. Jewett?
Yes, I'm ready.
Perfect. Am I pronouncing your last name correctly?
You are. You have it perfect.
Perfect. Wonderful. Thank you very much. I appreciate you being here today. We are looking forward to having your presentation.
Well, thank you. And I see the control there, so I will go ahead. As mentioned, I am Matt Jewett. I'm the Director of Health Policy at Children's Action Alliance. We are an independent voice for Arizona's children at the state capitol and in the community. And we'll hear a little bit more about our work as I go through my presentation. Our organization has worked a lot in the area of health insurance coverage, getting more children health insurance coverage, and then providing access to care. Insurance does not always mean access to care. Not all providers take all insurance, but we know that there is significant association between having health insurance broadly and better care outcomes. So in Arizona, the rate of children without health insurance, which is that top line or blue line, has come down considerably, and nationally it has come down quite a bit. Arizona has actually started to approach more the national line. If I were to take this all the way back to 1998, when the federal children's health insurance program was created that allowed states to create their state children's health insurance program. Arizona, about 25% of Arizona kids were uninsured compared to 15% nationally. Children are one of the least expensive groups to cover from an insurance standpoint, yet it is so important that they receive the care that gets them off to the right start in life. Going on to my next slide. There are quite a few disparities in health insurance coverage. I don't know if anything on this stands out to anyone. Before I looked into this, I probably would have thought that that maybe white children, non-Hispanic children were maybe the very lowest, and then everyone else would be considerably higher. I think what sticks out the most on this is that American Indian and Alaska Native children are about 2.5 times as likely to be uninsured in our state as pretty much every other race or ethnicity. And actually, Black African-American children now have state and nationally uninsured rates that are similar to other children. And a lot of that has happened because or since the Children's Health Insurance Program was created on a national level in the late 1990s. We do see other disparities as well, but obviously the American Indian Alaska Native stands out. And a lot of that is because American Indian and Alaska Native children and individuals have access to healthcare through the Indian Health Services, which is not insurance, but it is care that is provided free of charge through treaty obligations of the federal United States government. However, if people are traveling away from IHS facilities or they need certain IHS specialists that IHS does not provide, that is where insurance is extremely important still. Also, IHS facilities are not from a government standpoint, it is not an entitlement that is given. It is an appropriation that is made by Congress. And so having additional insurance that IHS facilities can bill is also important in providing care there. There are also disparities in the rate of children who are uninsured by income. Lowest income children are most likely to be without health insurance, in spite of the fact that Access, which is our Medicaid program here in Arizona, and Kids Care, our CHIP program, have been providing lower no-cost health insurance for several decades to that population. Also, I do not have a slide on this, but I can tell you that older children and teens and also young adults are more likely to be without health insurance than are the youngest children. And some of that is simply that parents tend to take in their young children for pediatric well visits with much more frequency. And I think that also tends to put it higher in the parent's mind, but also the provider's mind from the standpoint of pediatricians. Many healthcare providers, hospitals, community health centers provide assistance in enrolling in Access and Kids Care. So who qualifies for what? This is the federal poverty guideline, which is updated every year with inflation. It is not something that really says what people are able to survive on independently. This is a sort of rough formula that was come up with in the 1960s that has carried on. And right now, a person is considered to be in poverty based on federal definitions if they make less than $14,580. This is for 48 contiguous states. Alaska and Hawaii have their own, but if you live in Phoenix or Sedona or Winslow, it does not vary. It does not vary between living in Nebraska or living in California, just Alaska and Hawaii. And then, I lost my PowerPoint presentation there. I don't know what happened. I don't know if anyone can bring it back, but I can tell you, looking at that, thank you very much. Looking at that though, Access, which is our traditional Medicaid program that we've had since 1982 in Arizona, provides health insurance now to children as well as adults up to, they say 133% of the federal poverty level, but the first basically 5% of the federal poverty level is not counted. So it's really 138% of the federal poverty level. Kids Care is the Children's Health Insurance Program in Arizona that was created in the late 90s for, as I said, Congress and local leaders recognizing that the cost of health insurance is cheapest for children, yet very important, and yet they were the group most likely to be without it. And so Kids Care was created for those families who make too much for Access, but whose children still lack health insurance. Eligibility there goes up to 200% of the federal poverty level, but as a result of this year's state budget, will be raised November 1 to 225% of the federal poverty level. That should mean an additional 12,000 children in Arizona who will have access to low-cost health insurance through Kids Care. So that will go up to about $67,500 a year as the income limit for a family of 4. Not everyone who is eligible for access or Kids Care participates. In Arizona, the participation rate, which is that lower blue line, is actually a little bit lower than the national average, although it has increased in recent years. That may be that people don't know that they are eligible. I was just having a conversation with someone about a time when I was in my 20s and had some health issues and was uninsured between jobs and didn't know I was eligible for access. And then there can be administrative barriers as well. We have made that easier over the years as we have data hubs that can verify what people's income is through tax records. So they don't have to go and prove to a public agency what that public agency already frankly knows about them through things like tax records. So the state of Arizona already collects quite a bit of data on people's income. We withhold taxes, et cetera. So we've been able to make that a little easier through the years. We also have a network, as I'll talk about in just a moment, of over 200 organizations around the state, nonprofit community organizations that help people enroll. We know health insurance is important because children with health insurance are far more likely to have a usual source of care and a well child checkup. There are some disparities with specialist visits and access to specialists. Medicaid sometimes is criticized because it does provide usually lower reimbursement rates to medical providers than private health insurance. Yet it does not seem like in the aggregate that children with Medicaid or other public insurance are seeing really statistically significant difference from privately insured children in every area, at least certainly not on the well child checkup. And they look far more like those with private insurance than they do those who are uninsured when it comes to access to care. So why do Medicaid and CHIP matter? Various studies have found reduced rates of chronic illness and disability in adulthood, fewer hospitalizations, and basically better health, reduced mortality that continues into adulthood from having access to healthcare early in life. That also has translated into things like better learning and better earnings as those children become adults. What does access and Kids Care cover? They cover a special group of early and periodic screening, diagnosis, and treatment. It's a mouthful, EPSDT, which is basically what children need. It is a child-specific set of coverage that applies to kids, including routine visits and well child care. Adults in access right now do not have access to vision care or dental care, but we know that those are things that can be corrected oftentimes early on as we find those issues earlier, and we can correct things before they get more severe into adulthood. A whole lot of developmental screenings that might not apply to adults also are covered. I don't know why that went back. I apologize. Access also is involved with the Department of Child Safety and providing coverage for our foster youth in our state, but also the youth who used to be in foster care. The Affordable Care Act in 2010 extended health insurance to all young adults up to age 26 could stay on their parents' insurance. Foster youth who age out of foster care at 18 without being adopted don't have parents whose insurance they can stay on. So the Affordable Care Act allowed former foster youth to stay until 26 in Medicaid programs such as Arizona's Access. This is important because foster youth pretty much by definition have experienced some sort of trauma. And what we see is more than 35% of former foster youth will experience homelessness. More than 40% of former foster youth will become parents by age 21. I believe this is just those who were never adopted by age 18. Fewer than 3% will graduate from college. PTSD, twice the rate of combat veterans. And we know that there is tremendous economic insecurity as well for former foster youth. However, the state of Arizona, which does require annual enrollment to stay enrolled in Medicaid, and I won't read this entire story for you, but every year or every 6 months, depending on the population, people enrolled in Access have to submit a renewal. And it didn't make sense not to give continuous enrollment while we allowed former foster youth to stay in Access until age 26. They were still having to enroll every year, just like everyone else, in spite of the fact that they were automatically eligible. I think some of that was so that Access could determine which funding category and how much federal reimbursement they could receive. But people ended up falling through the cracks, including this young person who basically did not have a permanent address when she left foster care. As a result, the state was mailing her renewals to her caseworker's office, and that was not ever getting to her. And she didn't know she had to re-enroll to stay covered in Access, and she ended up with a tremendous amount of medical debt. We went to the legislature, I think it was in 2022, and were able to get that changed. So now that is one less bureaucratic hurdle that former foster youth have to complete. The Immigrant Children's Health Insurance Act, or IKEA, not quite as trendy as the furniture store, or maybe it is. Most states have now taken advantage of this. In the 1990s, through with welfare reform, the federal government put a 5-year bar on most legally residing immigrants before they would be eligible for Medicaid. Since that time, states have been given the ability to waive that 5-year bar for children and pregnant persons. And most states have taken up that option for one or both of those populations. And then there are actually 12 states and the District of Columbia that use state-only funds with no federal match to cover all children, regardless of their immigration status, including undocumented children. So in Arizona, we are one of the handful of states that pregnant persons who have had a green card, but for less than 5 years, ditto for children, do not qualify for Access. We also, as I mentioned, are part of a network of nonprofit community organizations throughout the state that can help people apply for Access. Sometimes if the state does not have income information, people will have to scan and upload their paychecks or other physical proof of eligibility. And many people may not have scanners, although increasingly we have cell phones with cameras, and we try to make it as easy as possible. But sometimes dealing with state agencies is not always as easy. And so we do have nonprofit community organizations that can help. People can find information by going to coveraz.org. There is a link on there where people can search for the community organization that has appointments in their local area, and they can schedule online. And I believe that is all I have. Thank you for accommodating me. I do have a noon training here in my office that I could not get out of. So, but I'm happy to take questions.
Thank you so much for your presentation, Mr. Jewett. For our board members, if you have questions, we're going to, just as a check-in, it's 11:31. Mr. Jewett does have to leave us at noon. Everyone will have the opportunity to ask him at least one question, but please kind of stay aware of the time so that we make sure to respect his time as well. Mr. Rose, you have your hand up, so I'm happy to start with you.
Thank you very much, Mr. Jewett. This was very informative in aiding our project. Some time ago, there was an article in the Arizona Republic that quoted you on the problems of people being taken off, children being taken off Medicaid. And I'm not sure whether I saw that discussed in your presentation as a very current problem in children having insurance, and I wonder if you could explain that.
Yes, thank you. That is an issue we've been working a lot on. During the pandemic, the federal government provided enhanced matching money to states for Medicaid to deal with, well, the pandemic. And in exchange, states were prohibited during the public health emergency from disenrolling people from Medicaid coverage in most cases. So that meant even if you were over income, even if you did not do the renewals that you would normally have to do every 6 months or 12 months to stay enrolled, you were not being dropped. And that is something that has since resumed. We're kind of back to normal, but you may have people who have gone up to 4 years without having to complete their enrollments. In many states, they stopped doing that altogether. Arizona, we continued doing that, but we just, if people didn't complete their enrollments, they would not be disenrolled. I think for a lot of people who live in tribal areas, who live in rural areas, there are often difficulties with receiving mail on time. There are also fewer community assisters to help people enroll. And so those have been some of the most vulnerable populations we've been most concerned about, who may not know that they have to do their renewals. We have had quite a few people who've lost care, but we know some of them were factually ineligible. You may have heard that about more than 3/4 who are being disenrolled are for procedural reasons. That can include bureaucratic red tape. The federal government is concerned about the wait time to get through to the phone lines at Access. We don't want anyone losing coverage for having to wait on the phone to talk to a state agency. But by and large, those that have been dropped are either over income or they believe that they are over income and are not returning their, they get a pre-populated renewal form if the state's not able to auto-renew them. And Arizona has one of the highest rates of being able to auto-renew people for coverage because we have a very robust data hub where we can find out whether or not people are eligible. But if people are over income, they get a pre-populated form saying, here's what we believe your income, your living situation, et cetera, is. If this, please return this to us with any corrections. If people don't return that, they are dropped. And that could be that they didn't receive the mail, or it could be that they thought, well, we're probably over income anyway. The thing is, the health insurance marketplace, healthcare.gov, that application can be forwarded by Access to the health insurance marketplace only if people return those forms. And that is by federal law. So people are losing out on an opportunity to look at possibly one other source of health insurance coverage, even if they are over income, because they're not continuing to work together with Access to make sure that Access is basically processing the renewals. So we're trying our best to kind of get the word out on that, get people into community assisters to find what they are eligible for, so that they can have no interruptions in their care.
Thank you. Do any other members have questions for Mr. Jewett? Christina?
Hi, Mr. Jewett. Thank you again very much for your presentation. I wanted to go back to the uninsured rates that you provided at the beginning of the presentation. I found the number that you provided for the American Indians and Alaska Natives to be really interesting. And I was wondering, do we have any further breakdown of those numbers? It's such a large group. So do we know if there are greater disparities amongst certain tribes or folks who live on reservation versus off, or is that aggregate data as granular as we can get?
It is very difficult to find. I've been looking for it. I have some data that I've been able to find, but it is not based on, I can find information basically geographically. I think that's how the census collects it. So we can look at uninsured rate by tribe if people are living on reservation. If they are off reservation, that is much harder. It seems, and again, the data we get from American Community Survey is sampling, and some of Arizona's tribes, like the Navajo Nation or the Tohono O'odham, are much larger, but many are smaller, and it's very difficult to really get good numbers anyway. But it seems there are tribes that have taken advantage of what are called 638 facilities. They basically are able to take the money that the feds would have spent on the Indian Health Services, and they can control that themselves and provide their own health care. And those tribes often, because they are running their own healthcare systems, it seems have lower rates of uninsured folks because they're more likely to want to get them enrolled and get extra to be able to get the reimbursement. But that's as good as we know.
That's helpful. Thank you.
Tessa?
So my question is actually very similar to Christina's, but I'm still going to ask it because I agree those are Arizona specific numbers on that slide. Okay. I think it would be interesting to know reservation versus off reservation numbers, because to me, if someone was living on the reservation, that would indicate that they're at least probably getting services through either these 638 or IHS services versus, Native kids who don't live on the reservation, but who may not be enrolled, but then may not have easy access to IHS facilities.
Yeah, that would be a good way to look at it. I can see if I can find that. That would probably be far easier. IHS facilities, I don't know exactly where all of them are. I know that in Phoenix, I can look right now and see the Phoenix Indian Medical Center from my office that serves a lot of people. I know that many local tribal areas have IHS facilities. They may, in more remote areas, not provide all the services that Phoenix Indian Medical Center has. I think that would be interesting to see rates of health insurance, but again, that might not necessarily mean access to the services that children need just by looking at that, because geographically they may still, if they're on reservation in, the Hopi Nation, for example, might not have as broad an array of services as they would if they were living in Phoenix, regardless of insurance status. If I find that, I can share it.
Thank you. Henry?
I'm Mr. Jewett. I'm Henry. So part of our task is to make recommendations to Congress. And unfortunately, when doing that, we come up against the biggest obstacle of all, the human attention span. So if we were to distill anything into one bullet point that we could put on the face sheet that, Mr. Jewett says this is the one bullet point that he, above all other things, wants done, what would that be?
I've talked to you about Access Kids Care, which is run by Access, the Indian Health Services, the health insurance marketplace. I've worked in healthcare organizations for 20 years, and I have difficulty figuring it out. If I'm having difficulty figuring it out, everybody is. There are a lot of different options, different ways of getting people covered, but they are so segmented that if we could simply make it easy for people, I think that would be the best thing. It sounds wonderful. Okay, you have Medicaid. If you're over income for Medicaid, you go to the health insurance marketplace. But with technology, those applications are supposed to go back and forth very easily. Do they? No. Do people get lost in the shuffle? Yes. We know that a lot of people are doing their redeterminations now, their eligibility redeterminations for the first time in several years, and they're coming back over income. We would expect a lot of those people to be going to the health insurance marketplace through healthcare.gov but a very, very small percentage of them are actually enrolling. I don't know exactly why that is, but the more you expect people to jump through hoops, the less likely they're going to have coverage. So I think making it simple, it's the old kind of KISS principle, in a healthcare system that is so heavily segmented. And I will shut up before I spend the whole day talking about, providers who don't talk to each other, who don't talk to insurance companies, which is a whole other matter.
Hey,
Thank you. I think have time for one more question for Mr. Jewett. Do any of our members have any more questions?
Great questions. Thank you.
Great. Thank you so much for your time. We really appreciate you presenting, and look forward to the additional information that, if you're willing to provide it, please send it to Kayla and she will circulate it to the rest of us.
Great. Thank you so much. And I will stay on
you.
until I have to go.
Wonderful. Okay. We will move on to our second presenter of the day, Dr. Murray Feldstein. Dr. Feldstein, am I pronouncing your name correctly?
Yeah, it's Feldstein. You can call me anything but late for lunch.
Sounds good. Well, thank you for being here to present to us today. We look forward to your presentation.
Yes, can I share my screen? Let's see, share screen. Host, I'm not allowed to share my screen. Can you permit me to share my screen?
Yeah, so go ahead and try again. It should be allowing you now.
There we go. Well, I'd like to thank the committee for permitting me to speak here today. The opinions I'm going to express are my own and do not represent either the official position of the Goldwater Institute or the Mayo Clinic, but they do represent opinions that I've formed over many years working in some of the most rural areas of our state and on the reservation, as well as towards the end of my career at the Mayo Clinic. So I'm going to start by saying that this is a slide that you might recognize that Dr. Dan Dirksen put up last time. And I just wanted to say that we know that we have problems with access to care. And I think they do lead to disparities in outcomes for different groups, depending upon how you aggregate or disaggregate your data, depending upon what you're looking for. I think we can show significant healthcare disparities. And that's the first of the 4 questions that is before the committee. And I'm going to address the 3rd and 4th questions, though, which is, what can we do about it? And is there anything in the structure of the system that we can do to change? And I would like to say Dr. Kirchner, for one thing, suggested tax credits for rural preceptors. And we heard today the problems we have getting health insurance for children. And I would say they're both important, but they're examples, in my opinion, of a downstream solution for problems that have been created upstream, that there is a dam in the way we provide healthcare providers to the public. And unless we can breach that dam, the water that will provide the access can't get to where it's needed. So what I'm going to talk about today is that there are significant lack of healthcare providers of all kinds. And I've been in the profession since before we had even Medicare or Medicaid. And I can tell you that we've been trying to solve these problems, spending millions of dollars over the decades. And unless we address the upstream obstacles that we will just be treating symptoms and not the causes of the problems. And I think we need many more healthcare workers of all types and many more from disadvantaged groups. And the theme of my talk today is that increasing healthcare access for all Americans will reduce disparities, especially for the poor who are hurt the most. Now, we're not supposed to be talking about acronyms today. So these acronyms are just, don't worry about what they mean. They just each represent a private, non-for-profit healthcare organization controlled by doctors, and they are the ones that limit the number of medical schools and thus the number of doctors available. They're the ones that regulate internationally trained physicians who come to this country trying to make up for some of the lack of healthcare. They're the ones who regulate postgraduate education that provides the numbers and kinds of specialists we produce. And none of this would be important. All organizations have ways of doing this. But what's different with medical doctors is that through, if you know anything about medical history, through excellent lobbying in the last century, physicians, through the medical licensing laws, can limit what anybody else can do through what are called scope of practice regulations. And healthcare, as with anything that's scarce, are going to hurt the disadvantaged and poor the most. Now, this is just a diagram of what the last slide said. And it was published in a research paper by the former dean of the Harvard Medical School and an expert in public health who runs a research program at Dartmouth. And what they point out here, and the words on the slide are theirs, that these organizations are not responsive to the needs of the American public, and that their interactions reflect a very complex and non-transparent nature of these organizations. And through the power they wield, through the state legislatures, which have basically outsourced their authority to these organizations, they're able to seek protection from potential competitors at both the state and international and national levels. Now, I'm going to talk a little bit about what goes on nationally. In 2023, there were, I think, 158 medical schools. There were 62,000 applicants and only about a third who actually were accepted and graduated. Only 1 in 4 were applicants from lower socioeconomic groups, and only 1 in 5 were accepted to medical school. And it's not because the people that were rejected weren't qualified. 15 to 18% were top GPA scores in their classes and had excellent scores on the medical college admission test that they have to take. There really was no objective reason for the rejection, just not enough room in the American medical school system. And many of these rejected applicants from America went on to international medical schools for training. But overseas training is expensive and it favors advantaged groups. Now, you might not realize that 25% of licensed physicians in this country come from foreign medical schools. And approximately 18% of them were American students rejected here and who went overseas and then have come back to practice. The organization there, the organization that regulates these graduates, makes it a bit harder for them to come here and practice what they've been trained to do through some restrictive regulations. The other thing is that our programs, our educational programs to get into practice are getting longer and longer for many reasons. You know, the more knowledge we learn, the more specialized we become. Our programs are becoming longer and longer. But there's another reason as well. Medical reimbursements do not reflect the public's healthcare needs. And we get reimbursed on the basis of negotiations between special interest groups, insurance companies, and government agencies. Now, when you think about it, longer training logically justifies higher negotiated fees. And I think this is one reason that we incentivize longer training programs and a surplus of specialists with a shortage of primary care providers. And the other thing is that non-medical doctors, such as advanced practice nurses, pharmacists, psychologists, physical therapists, are all excluded from getting some advanced training that may allow them to practice more proficiently in the disadvantaged areas they serve. Because of human nature, and in spite of our best efforts, without competition, there's really no incentive to devise more efficient training or practice models. Now, our current licensing regulations discourage non-medical doctors like nurse practitioners and physical therapists and pharmacists from providing unmet healthcare services. I'm happy to say that Arizona is one of the better states when it comes to letting people get licensed in practice. And I'm proud to be associated with an organization that has helped influence that in the state. But the fact is that doctors are licensed to practice any service within a broadly defined standard of care. For example, as a urologist, I have never been trained for or performed open heart surgery, but it may surprise you to realize that I'm legally entitled to do it. You do not want me to do that to you. There are other things that keep me from doing that, but it is not the license to practice. Now, scopes of practice for nurses and pharmacists and nurse anesthetists are different in different states. They're much easier for a nurse practitioner here who can prescribe medicine independent of a physician's supervision, but not in California. And in the state of Delaware, it takes 4,000 hours before a nurse practitioner can do it. So what's the difference? The fact is political influence and not competence is the decisive factor that regulates the scope of practices in different states. And if any of you have been embroiled in a turf battle in the legislature, it is an ugly, ugly thing. I don't wish it on you. There are political obstacles to introduction of technologies that could improve diversity and access. Telemedicine has been available for almost 2.5 decades to be able to do safely. It took a pandemic for us to loosen the hold that special interest had over the provision of this and reimbursement for this. And we don't know how we would do without it. There's also going to be an increasing use of artificial intelligence and algorithms that will permit lesser trained providers to safely provide more complicated tasks. And we should be looking at our state legislature to expedite those much improved needs to patient access. Not only that, but the current system favors a workforce for more affluent groups. A 4-year college degree is required for most medical school admissions with few exceptions. This by itself favors affluent populations. It also may surprise you to know that many advanced countries like Germany, France, and Italy, and other OPEC countries don't require 4 years of college. They move what's needed to be practicing in medicine within the professional school itself, immediately cutting out 2 years. The other thing our system does, and I can speak to this from experience over many years and in many places, that it disregards the lived experience of people from disadvantaged groups. People from disadvantaged groups also need to be able to work in order to continue their training. There's ways of doing that, and we can discuss that if you want. But if we could somehow empower people who are getting trained to work and removing, and we would make it easier for disadvantaged groups to practice. And I think that removing barriers is a better way to promote the getting rid of inequities than either a push up or a handout. That let people work to their capabilities, and they will surprise you how rapidly they can advance. Now, this is an alphabet soup of different specialties within the healthcare system. I won't go through each one. You may recognize some of them. But what I want to tell you is that every one of these professions is that, except for medical doctors and osteopaths, have to fight turf battles to be able to practice what they've been learned and certified to do. I'm telling you that diplomas are a proxy for competence. We license diplomas, but instead I think we should certify competence. And if you want to talk about how osteopaths came into the picture, that's another whole story, but it proves my point. A couple years ago, a noted healthcare economist, Dr. Grayboy, and myself published a research paper that made recommendations of how we could modify and reform our system that would make it easier to do the things that we could do to increase access. One of the things we suggested, among others, is to license physicians like we do airline pilots. Now, the two professions are different, but they have this in common. Both airline pilots and healthcare workers are responsible for the lives and safety of the public who depend upon their critical skills. And I would think that an airline pilot has more people on a moment-by-moment basis dependent upon his skill than somebody like myself who hasn't taken care of acutely ill patients for many years. A pilot's license is non-politicized, and I used to fly, so I can tell you what it's like. But there's no statutory or de facto limitations placed on the number of people who could enter the profession. And you don't have to go to a government-approved flight school to get your training. And once you are certified by meeting previously established, transparent and objective criteria of training, knowledge, and skill, the state legislature, no legislature, can prevent you from going to work and getting compensated for the skills that you learned and practiced. There are other major differences in the way that we train doctors and we train pilots. I'm happy to talk about them later if you wish, but the number of pilots and the type of training they undergo is much more needs of the public, which is why, since I've been in medicine since 1963, we have always had healthcare shortages. The pandemic has left us a bit light on pilots, but I bet you they meet their needs much quicker than we ever will. Now, I'm going to recommend the way we would do this is that each state or any state could abolish the monopoly licensure system they have. We already have panels of qualified professional boards that we allow to certify. And I think professional boards should only have two responsibilities. First, determine what their own transparent criteria are for training to certify competence and testing. And then to evaluate, discipline, dishonest, unethical, impaired, or incompetent practitioners. And I am currently a medical consultant for the Arizona Medical Board, so I can tell you how that works. But the one thing they should not be allowed to do is they should not regulate competence in other professions. I think all certified practitioners should practice at the top of their license. And I think what will happen then, under the incentive of competent competition, that we will change the way we train newly eligible students. So what might this look like and how would it work? The black arrows on this particular diagram are how we currently now train healthcare workers and let them do things. And then on the y-axis is the number of years after high school. So after high school, you have to go to 4 years of college, 4 years of medical school, and take 2 years of postgraduate work, 1 or 2 years of postgraduate work before you'll be eligible for a license to practice in any state. But that's at least 10 years. And if you're going to subspecialize, for example, in my specialty of urology, and I taught residents when I was at the Mayo, it could take as many as 14 to 16 years after high school to get into practice. Well, what does that do for people who couldn't go to college because they couldn't afford it. Let's say a battlefield medic with lots of experience, or a certified operating room technician with plenty of experience in an operating room, or a nurse practitioner, a doctor of nursing, who's already had 8 or 9 years of college. What if that person wants to do a simple skill in their particular practice or where they work, but they're not allowed to do it because their license won't let them? They have 2 choices. They could go back to college if you're a paramedic or an Army medic, and then go through 4 years of college and graduation. Or if you're a nurse practitioner, they might allow you to use some of your practice to go to medical school, but you still have another 4 to 8 years to do something that you could probably do within a week with the proper training and do it competently. The blue arrows that would let them bypass this is what our recommendation would allow them to do. Would it be safe? Would it be safe to let these people? And I would tell you that it's not my license that keeps me from doing heart surgery. There's non-governmental standards and practices that are more important than licensure. Hospital credentialing, continuing education requirements, professional recertification, compensation and panels, malpractice outcomes, and the kinds of reviews we do for quality assurance are all more important. There's also a moral compass that most people have. I won't do heart surgery because I'm likely to kill somebody, and I don't want to be, as a human being, responsible for that. Each of these non-governmental standards will become more important in the kind of reform that we envision. It also would be easier, and I can talk from long experience on this, to scrutinize the unethical, dishonest, impaired, or incompetent practitioners and get them out of practice much easier than we can do today. I'm going to conclude by saying that 21st century healthcare is regulated by a 14th century mentality. Our medical system is the legacy of the medieval guild system. The American Medical Association influenced the closure of more than half the medical schools in this country a century ago. And that was at the time when there was a significant amount of institutional racism. Schools catering to women and lower income white and Black students were almost totally eliminated. Ladies and gentlemen, we have fewer medical schools today than we had a century ago. And for my 60 years in medical practice in some of the most rural areas, as an instructor and an assistant professor at the Mayo Clinic, as a politician who was successfully elected to office twice, I want to tell you that I believe that individual talent, ambition, dedication, hard work, and skill are more important than the initials behind someone's name. And that the science of practice of healthcare is actually a continuum and should not be parceled into silos of training and licensure. And if other people say, no one but doctors can do this kind of work, I would like you to ask them to justify that with evidence. So I'll stop there. I want to thank you for allowing me to talk. There are references upon request that I can email to you if you wish it. And I'll yield the screen at this point if I know how to do it. Let me go back. Whoa, let me get out of here and go back to Zoom. Uh-oh, I think I'm out of Zoom. Let me get my window back. Zoom.
Thank you for your presentation.
I can't get into the
I
Zoom
think-
window.
Kayla should be able to help you. There we go.
There, thank you very much.
Thank you. That was very insightful. Do any of the members of the committee have questions for Mr. Feldstein? Jonathan, your hand's up. Oh,
Madam Chair, I thought we were going to wait for the
Oh.
other 2 presenters before we ask questions, but
You
maybe I'm
are
wrong.
you are absolutely correct, David. Jonathan, would you hold the moment on your question, and we will hear from the next presenter, and then we will each individually ask a question. Dr. Page, I appreciate you being here today, and we look forward to your presentation.
Thank you. Kayla, would you put my slides up there? Or do I have access right here? There we are.
Yeah, there we go.
All right. Thank you everyone for having me here. I am a pediatric ear, nose, and throat specialist at Phoenix Children's Hospital and otolaryngologist. I was asked to be here in my role as the chapter champion for the EDDI program for the Arizona chapter of the American Academy of Pediatrics. And there are many people in this state with more experience with this program than me. I feel privileged to be able to speak on behalf of many of them. And I think there's a lot to be learned in the process of sorting this out. So I want to start by explaining the program, what it represents, and why I think it is a good fit for some of the discussions that you're having here. And then I'll show you what I was able to pull together. Realistically, I think I have less actionable data than other people have presented so far today. I think there's much more to be learned about what we can do to gain the information we need to make steps forward here. So the EDDI program, the Early Hearing Detection and Intervention Program, is a federally funded program that is administered on a state level. This is from the Health Resources and Services Administration website, and I want to highlight this part of their goal. The goal is to ensure that children who are deaf or hard of hearing are identified through newborn, infant, and early childhood hearing screening and receive diagnosis and appropriate early intervention to optimize language, literacy, cognitive, social, and emotional development. That is what lies behind the EDDI program and the many people that work on it in these states. The program is funded by Congress and has to be reauthorized every so many years. This was a long authorization through 2027. And then individual grants are given to states and territories to fund their system. And so there is data collection on a state basis and then evaluation of the program and its successes as part of that. Then that reporting goes back to continue to support those grants in the future. These are, again, from the HRSA website. Some of the impact noted is that in the 30 years since newborn hearing screening has become universal, 98% of babies born in the US are screened for hearing, typically before they leave the hospital. In the last 18 years, over 84,000 deaf and hard of hearing children have been identified early because of the program. And they estimate that $200 million in education costs are saved each year because of the screening program. Now, this is in large part because of reduced need for resources later on for children who, by receiving early identification and early intervention, are able to meet their academic potential without requiring the additional help, aids, et cetera, as they get older. The underpinnings of the EDDI program come from this organization, the Joint Committee on Infant Hearing, which is a group put together by a number of different professional organizations back in the late 60s, and who focused efforts initially on gathering data to determine if newborn hearing screening was appropriate, and then putting together guidelines and principles that would help govern that process over our country, and in fact, around the world. Other countries also base their screening programs in large part on the recommendations of this committee. But their most recent position statement was in 2019 and echoes what we heard from the federal government. The goals of early hearing detection and intervention are to maximize language and communication competence, literacy development, and psychosocial well-being for children who are deaf or hard of hearing. The Joint Commission, the most recent iterations of their program emphasize this three-pronged approach. And everyone who's in this world knows the 136 guidelines. So I want to explain those here. The three parts of the program are admission, birth admission screenings, that is screening of the babies at the time of birth. The second step is to have a follow-up screen and diagnostic testing as indicated based on what we learn at their initial screen. And then finally, early intervention for those children who are found to have hearing loss. These are set up to be done at the 136 level. So 1 month, all infants should be screened for hearing loss by 1 month of age. The 3 is that all infants should receive diagnostic testing by 3 months of age. And finally, all children who are diagnosed with hearing loss should be enrolled in early intervention by 6 months of age. And there are data demonstrating that meeting these guidelines is beneficial for speech and developmental outcomes. These data are reported to the CDC annually by every state with an EDI program and utilized to track progress over time. I want to walk through the process a little bit because I think it's important to understand this to know what we're looking at as we consider the data going forward. Every child starts with an inpatient screen. If in Arizona, as with other places now too, a fair number of children are born at home or at birthing centers. And so participants in this program at the state level have gone to great lengths to get equipment and train screeners into birthing centers or to train midwives to do screening or other things so we don't miss children who are not born at a hospital. Now we're very successful and over 98% of children are screened in everything. If those children pass that screening test, then they're out of this program and they no longer have any part in this diagram. If they fail, or what we call refer on that initial screen, then they follow up for an outpatient screen. And there are a variety of programs that are set up to do that. They're often done at the birthing hospitals. If the patient passes their outpatient screen, again, out. They are passed and they move on from there. If they refer or fail again on their outpatient screen, then they're referred to a pediatric audiologist who has expertise to be able to diagnose hearing loss in infants. The goal is for those initial 2 screening steps to happen within that first month. If that baby fails, then the goal is for this diagnostic test to happen within 3 months, 3 months of birth. So for children who go through the diagnostic test and have normal hearing, then again, they're out. We don't worry about them anymore. Children who are then diagnosed with a permanent hearing loss are now to be enrolled in the early intervention programs, and there are a number of those that I'm not going to fully address today. One of the challenges that we face is getting children through those programs. So at every step, we have children who are lost to follow-up, and the LFU category is one that is important in the annual report that's given by each program, and great efforts have been made over the years to try to decrease that loss to follow-up. This is an example of the data that are presented to the CDC every year. This is a lot, and I don't ask anyone to try to review this, but at the top, you see the 136 categories, and these are, again, to emphasize how many kids were screened, how many kids were diagnosed, how many kids were referred appropriately. And then they track the exact reasons you can see on these categories about all the reasons why somebody didn't make it to that step and how many there were. This is a fairly involved process as follow-up with all the people who didn't get screened, all those who didn't get diagnosed, can be time intensive. That has been handled in different ways at different times. The state has had contract with a parent advocacy organization called Hands and Voices, or with Ear Foundation, a nonprofit organization that works with people who have hearing loss, and contracted with them to do additional follow-up calls or efforts like that to try to gather more data and get more children diagnosed early and into intervention early. And those have been fairly successful over time. In fact, some have been very successful in decreasing the loss to follow-up rate. But those are limited contracts, and currently there is no contract to perform that kind of follow-up screening in Arizona. Now, this committee heard a discussion at the last meeting or 2 meetings ago that specifically addressed EDI as a potential source of data to evaluate healthcare disparities, pediatric healthcare disparities. And this is the information that I was given to discuss and look towards. So about 6 weeks ago, when I was contacted with this, I immediately began making contacts with other people who participate in the EDI program in Arizona, and with the group at the state health department who manages this data to try to put this together as quickly as possible. And I faced a number of obstacles. And so I'll present today what I have, but I'll also, I think, describe to you some of the challenges we have in answering these questions in a definitive way. So you can see down this list all of these variables that were requested for us to discuss. The big issues are who did not receive a diagnosis appropriately or who has lost a follow-up, who received a diagnosis but later than they were intended to be or according to our current guidelines, and how many were actually diagnosed with deafness or hard of hearing. And then our idea was to look at those with these various variables: race, ethnicity, geographic location, NICU stays, single parents, prematurity, insurance, language, congenital infections. And so this is what I approached our group with. Here's what we were able to come up with. So race and ethnicity is documented. Typically, it is the caregiver's race and ethnicity. So usually that's the mother. Geographic location, they were hesitant to share because of concern about privacy issues. We don't document a NICU stay over 5 days, which is the risk factor that is typically used, but we do document NICU versus well baby nursery. We don't have any way to document single parent households. We have some information on prematurity. Insurance type, genital infections, and language spoken are not documented. Language spoken is on the data collection list, but when we look to review that data, over 95% of patients were left blank in that category. Congenital infections are not documented at all. I participate in an organization that focuses on bringing awareness to congenital CMV, the most common acquired cause and congenital cause of hearing loss in children. And Arizona has no screening program for CMV and no way to collect data on CMV. Insurance type is not documented in a way that allows for extraction from the data. We did find maternal education listed, which in some public health scenarios has been used as a proxy for other socioeconomic indicators. So we did pull that data. But as you can see, this leaves us with a lot less than we would hope to obtain. Now, as you will see with this first slide, this is data from 2019. The reason for that is that the state health department was not willing to share more recent data. 2023 is of course still in progress. 2022, they felt that there was still a lot of follow-up to be done, and that's an issue. As you see, some of these babies need to be followed for 6 months. So babies born in December, we may not even have that data until June of the following year. 2021, they felt that there were still details that needed to be done. 2020, they felt was not a good representative year, and so they shared with me data from 2019. When we started the process, I agreed to take 2019 in the hopes that that would be our initial step so that we could gather the remaining years and be able to evaluate that. But I will say that some of this data I received this morning. So this is an initial step looking at children who had their initial healthcare or initial hearing screening. And you can see on the left column is patients who passed, and that's going to be the majority of kids. The second column is those who did not pass. And the final category is no result, which means they were never screened. And this is broken down in this slide by race. The large orange and these are self-reported race. So that is white or Caucasian, green is Black or African American, yellow is Asian, and red or maroon there is Native American. There is a small increase, or maybe a significant increase. We don't have more data to evaluate that, but in the Native American population in that not passed group, but minimal difference in the no hearing result group. If we look at that same category, but with children who failed their screen but did not receive a diagnosis, we do see a significant increase in the Native American population and the percent of children who did not ultimately receive diagnostic testing for their failed screening. When we look at that by ethnicity, we can split it by Hispanic or non-Hispanic, again, self-reported. And there is some variability there. As you'll see on these, this is for the initial hearing screen. The subsequent slide here is for the diagnostic screen, and they're relatively even in those cases. When we look at that by maternal education, we see that, to point this out here, we start with less than high school education, high school, some college, and graduated from college. So the high school graduating line is here at the top of the yellow, between yellow and green. And so as you go from passing to not passing, children whose mothers were did not graduate from high school or just graduated from high school are more likely to be in the category that did not pass. But in this year, we're not more likely to not have a hearing result. We see that in fact, the group with higher education was more likely to be found in not having the diagnostic result obtained, or sorry, hearing screening result obtained. In those who failed their initial screening, we do see an increase in the likelihood of not passing or not receiving a diagnosis in the group with lower maternal education. In the population of children who have been confirmed, who made it through the screening and diagnostic and were confirmed to have deafness or hearing loss. These slides are time-based. So the first column is they were diagnosed before 3 months of age, which is our what the guideline that we're striving to achieve. Second group between 3 and 6, and the third group diagnosed after 6 months of age. And you can see a couple of things. One is the increase in blank, that is race not identified, as well as the increase in the likelihood of Native Americans being diagnosed later than other groups. In the ethnicity group, it is less clear. It looks like the Hispanic population, which is again the red category, is more likely to be in the middle delayed group, but less likely to be in the more delayed group diagnosed after 6 months of age. The final group here, this again is maternal education, and we do see an increase in the likelihood of children being diagnosed ultimately with their hearing loss in the groups with lower maternal education. I had hoped to obtain some geographic data as well. Dr. Feldstein reported on some of the issues about rural issues in Arizona, and we have obviously a significant difference between patients who live in the main corridor of the populated area of the state and those in far-flung outlying areas where hospital care is lower, provider accessibility is lower. And I met a considerable amount of resistance in sharing those data, in particular because of concern about the low numbers that might occur in lower population counties and their concern about privacy potentially being violated. I did get this document that showed from 2019. The blue lines you see are the passing numbers. The reds are not passing, and the yellow are no result or loss to follow-up. And this is by county. And you do see some variability by county, with our county that had the most challenging numbers, Cochise and Gila County. The numbers for loss to follow-up are actually significantly greater than this. So if we just take the group that did not get screened in this first step and we look at how many of those we are able to bring through the rest of the study, those numbers can reach 50% over the last couple of years. That we have that in the broad strokes because that's required reportable data to the CDC, but I was not able to obtain any of that on a racial or ethnic level or in geographic format. So some conclusions. EDDI data really is an ideal source for evaluating disparities because it is a program that is designed to provide care, equal care for all children born in our state. If we can't demonstrate that we're performing that equally for all children in our state, then the disparities will become obvious. There have been a few attempts to do that in the past, although from speaking with various experienced members of the EDDI group, nothing like that has been pursued over the last several years. Some of the studies have shown surprising findings, such as in 2016 when they determined that Yuma had the lowest loss to follow-up rate of any county in Arizona. For the initial hearing screening step, they were very successful. However, when it came to diagnostic testing, their numbers went through the roof because there is no pediatric diagnostic audiologic testing in Yuma. And so all those patients were required to come to Phoenix for additional testing, and we lost a considerable number of those patients who, by the way, would have had to go through a couple of border control checkpoints on their way to get their child tested. So to determine where we stand with that now was extremely difficult. The current paradigm, the way the data is managed, leaves difficulty in gaining access to it. In the defense of those managing the data, the time frame was short. We tried to obtain all of this in the last about 6 weeks. But that being said, I am still disappointed with what we were able to obtain in that time frame in being able to try to attempt to answer these questions, both in relevance and in timeliness. I think we need an organized effort to be able to streamline the process to get these data, both for annual reporting of potential disparities, as well as for ad hoc analysis. As situations arise where we want to evaluate these specific issues, we need to be able to have a mechanism in place to be able to obtain that data and review it. This has been successfully done in a number of other states, and absolutely we have the capability of doing it here. I think also we need to give consideration to what we collect. Some of the lack in our data was not just from lack of access, but from lack of availability of data. We don't collect some of the information that we need, or we don't collect it at a significant proportion of the patients enough to make it relevant enough to be able to use and evaluate. I do think, in a positive note, I would say that there are very interested parties, and we have already in this process put together an even stronger coalition to be able to work towards accomplishing some of these things. At the state level, there's also work to be able to bring some of these public health databases into alignment with one another so that that information can be shared better and analyzed better across different platforms. And that's all I have. Thank you.
Thank you very much for your presentation. Okay.
There are my acknowledgements. Just, you know, there are a lot of people that helped me in that process.
Thank you for that comprehensive analysis. If the committee members have questions, you can raise your hand. Jonathan, you don't have your hand raised now, but you did have your hand raised before. So I wanted to give you the first opportunity to ask your question of our presenters.
Okay, can you hear me?
We can hear you.
Yep.
Okay. I have a question for Dr. Feldstein. I found your presentation very interesting and actually familiar. I spent many decades focusing on antitrust and spent some of it on occupational licensing and the way doctors, lawyers, and other professions limit competition. As early as 1943, the AMA tried to prevent group practitioners from having hospital access. So it's a very old story. But my question to you is this. I didn't hear anything in your presentation that ties directly to what this study is about, disparities in healthcare for children. So I would like to ask you if you could comment more specifically on what you said and how it relates to disparities in healthcare for children, other than simply the shortage, which is a serious problem, of medical practitioners and the limitations on practice by paraprofessionals.
I can't answer your question directly, Mr. Rose. I realize that the committee is specifically interested in children. All I can say is that it's a subset of a larger question, and I don't see the problem with raising the larger question, because I think it will also, by improving access to all of us, it will also improve access to children as well. So you're exactly right. My comments were meant to improve access in general, but I can think of hypotheticals that would say that in areas where there are no pediatricians, or in areas where there are no family doctors, you can have well-trained people who, say, grew up in that area, who could serve competently to examine children, get them immunized. You know, pharmacists are within a few miles of almost every population center in this country. In this state, up until a few years ago, pharmacists were not allowed to give immunizations for the very reasons that I discussed here today. Now, I don't know about you, but I have been nowhere but to pharmacists to get my COVID shots. And it's much easier than going, for example, where I worked for the last decade and a half of my career at the Mayo Clinic. And so what I think would happen, and by the way, pharmacists are still precluded, I believe, from giving the youngest children vaccinations. And I can't think of a reason for that that has to do with their competence to do that. So there's a good example of what we could do if we freed up professionals at all levels to work in the communities and meet the needs of the populations they face. That would be the way to go. Now, during COVID, I volunteered with the Marion County Department of Public Health and went out and vaccinated through the whole year of 2021 in many areas, including migrant camps, down in the district, the zone in Phoenix, and things like that. And it was a team of nurses, doctors, medical assistants that did all this. And I don't think you could tell what profession we were when we went down there. We were just all up to our ears in getting people vaccinated to the best of our ability. And that is the kind of thing I expect us to meet. The very real challenges to getting kids get care is the same challenges getting old people and young people and adults care. The same barriers exist for all of us. So I can't answer your question any more specifically than that.
I would only add that my own profession, lawyers, prevents many competent people from doing things that they're fully qualified to do. And it's just as bad or worse as the medical profession.
I would like to correct only one thing you said, Mr. Rose. The lobbying started well before 1943. It actually started in the late 19th century. They totally eliminated a number of professions that were not doing bad, such as homeopaths and eclectics. Chiropractors were regulated, but a lot of people who were out there, so that lobbying was coming to fruition largely by 1943. It didn't start then.
Thank you very much. I remember Henry, he has a question. Go ahead.
Sure, and to tack on to Professor Rose's comment, being an attorney myself, I'll say that the ABA qualifies many people who are still incompetent after that. But anyway, that aside, Dr. Feldstein and Dr. Page, you probably heard me ask Dr. Jewett about the bullet point question, and I'm going to ask the same thing of both of you. We're supposed to present Congress with some concrete, actual things that they could do. Whether or not they get it together to do it is up to them. But Dr. Feldstein, I would take it that you would, if I were to put a bullet point in there that says allow pharmacists to vaccinate or otherwise, inject children with life-saving medicine, that would be perfect.
I could be more specific than that, Mr. Whitmer. How about a bullet point that reads like this? And you don't have to go to Congress, go to the state legislature and ask them to look at as Arizona statute 32-1421, which now makes exemptions to what can be practiced by non-doctors. For example, medicine men on the tribal reservations are exempted from the Medical Practice Act. They can do what they want. And religious practices, they can do what they want. So we could perhaps look at that escape clause and rewrite that to look something like this. that any practitioner who is certified for a scope, a practitioner may scope a practice within a scope of practice for which they have been certified as competent by an accredited professional board approved by Arizona statute. We have the power in the state if we wanted to do that. It's as easy as that, but I got news for you. It would be the hardest thing in the world. There's nothing medical to stop us from doing it, but politics and bureaucracy, it would take, it's massive to get the inertia out. But if you could marshal the forces to make it politically possible, something like that, and you'd have to consult an attorney, obviously, and legislatures, but something in the line of that in one state, I feel would steamroll to other states. We've proven that at the Goldwater Institute already by getting state exemptions for the right to try law that the Goldwater sponsored. And so, and also our universal licensing reciprocity is being picked up in other states. Something like this, I think, would steamroll. So I don't think you have to fight Congress. You have to fight something even more difficult, the Arizona state legislature, and the political interests that do not want to be moved at this point.
So to follow
Thank
up
you for
on
the
that,
question.
we're a federal commission, so we have to make federal recommendations. Is there an allegory under USC that you know to 133401, 3407, 3408?
No, actually, the federal government's better than the state governments in allowing their practitioners. People can do things on the federal facilities. For example, in the Indian reservations and the veterans hospitals and the Army hospitals, they have done things with non-medical doctors on their own facilities that we can't do in the state of Arizona. It took us years to get CRNAs to be able to practice anesthesia on par, but they've been doing it in veterans hospitals and places like that more recent, more efficiently. But
So Leslie,
I'd have to look at the state. I'd have to look at the federal regulations to know how to go there.
Leslie, cut me off if I'm dominating time too much, but Dr. Page, same question.
Yeah, I think on the federal level, the EDDI program has been now reauthorized, as I said, for 5 more years. And they placed as part of that some, I guess, guidelines, I would say, that they want to see some data brought back in. And what I noticed in my experience is that the team is very motivated to accomplish that and to get that required data done and get that reporting done. But the questions I brought up were not part of their routine, not part of their practice, and not required for any reason. And so while I'm hesitant to say that I would want all this to be required as additional reporting, I do think that we may need to find a way to strengthen the understanding that the data team has at the state level in knowing that this is something that is necessary for us to solve the problems. I would say I've seen data now from a couple of different states that are practical and actionable. And while the Arizona has made progress over the years in terms of getting more kids screened, for example, we don't know where our difficulties lie. We don't know where the pockets are. We don't know if they are the rural corners of the state, or if they're underprivileged areas of Maricopa County, or if they're people who don't speak English, or we don't have any really good understanding of where our major issues lie. And without that, it's very hard to make a concrete recommendation to the United States Congress about what to do. Because in many ways, I think we have not provided for them what they would need to make good decisions.
So what states were those that had good data?
The ones that I've seen recently, and this would not be a comprehensive list, but Iowa, Kansas, Illinois, Actually, Amanda, who I think if she's still on this call, did some of that data work. And I was able to see her. She was on earlier. She may have dropped off. But Amanda Hagerman, who presented at the last meeting, did some of that work in Iowa. And they were able to find very specific data. For example, seeing that, I believe, actually, this was not her data, in Illinois, that Black children were 25% more likely to be lost to follow-up than any other group. And so that made it easy for them to then say, okay, well, next year, our goal is going to be to focus on this population and see how we can bring them up into line with everyone else. And while we have suspicion of some of the very things that come up in the other presentations, I think we don't have solid data to emphasize where that is. I mean, I can echo Dr. Feldstein in saying that we see children from the reservation all the time who have had delays in care because of lack of access to providers. And so that's going on all the time. And if there's lack of access to pediatric audiology, for example, then those children get delayed. And so we see them showing up much later, and that leads to decreased outcomes, decreased speech production, need for additional resources for them as they go further in school. And so that's an actionable area. We could say, if that's really the case, if this is a Navajo Nation issue, or if this is an issue of Native children within the throughout the state, that's something we can go after. But we need to be able to have access to data more robust than what we currently have to really work through that.
Thank you.
Dr. Page, I'm going to use my question to kind of follow up on Henry's question. In your conclusions, you said an organized effort must be made to streamline the process to obtain data for annual reporting of potential disparities and then ad hoc analysis. You noted that other states were doing that. The other states that you were referencing in that arena are those Iowa, Kansas, and Illinois?
Those are the ones that I'm most familiar with. Because these are state-run programs, every state has an entirely different way to do it. I actually attended my first national EDI conference last year, and they have representatives from every state. And it was really inspiring, actually, as to see this group of parents, audiologists, medical doctors, speech therapists. I mean, people with in every area who have interest in children with hearing loss coming together and really sharing everything they could about how to improve the situation in their own state. And we took some great information back from there, but to really honestly assess what we're doing, looking specifically at healthcare disparities was not on our list, and we did not make those specific moves going forward. And I think I thought when I got these questions, oh, I'm going to pull this together. We'll do a quick analysis and we'll have some great stuff to work with. And in coming through there and saying, I mean, after 6 weeks of fairly devoted effort, I cobbled together some 4-year-old data and still leaving us quite short of what we would want to have in order to be able to answer these. And maybe given 6 months, we can pull together something much better than that. But a lot of the way that these are done on a database management level is that you create a report, you create a query that lets you pull the data, and then you can repeat that as often as you need to. And it becomes very easy to do the same things. And so I don't know, each of those states did their own thing, but they were all sharing some of that information at that conference and since then as to how they were able to accomplish it. So I think we can gain from what they've done and apply those to our system.
Thank you. Dr. Feldstein, it seemed to me that you were indicating that one of the barriers to having more doctors or more medical providers as a whole was this portion of medical education that I'm particularly interested in, which is the portion where you are, in essence, working but not being paid for that work. You are studying it within the hospital setting, you are working a full-time job without being paid, and how do you give access to people from lower socioeconomic arenas when you really are working a full-time job and not getting paid for that? What suggestions do you have to alleviate that disparity?
Well, you know, I don't think I was particularly wanted to emphasize what you would be doing within the time that you were getting accredited or getting certified. Things are a lot better throughout the profession now than they were when I was training. When I had to work my way through medical school, we had children, and I had to work at night, frequently at a laboratory across the river from Philadelphia, drawing blood and doing lab tests and doing AKGs to supplement our income while I was in medical school. I didn't expect to be paid that much during my training and my internship. We don't have internships like that anymore. I'm not sure if that's good or bad, but I worked basically on for 24 hours and then off for 12. It was not what it is now. And we weren't paid very much. You get paid for much better now in your residencies than they did 30 or 40 years ago when I was in my residency, 40 years ago. So what I was thinking more in the area of somebody who could go to community college and make up some courses without going to college. And over a period of a couple of years, they could take courses, preclinical courses in basic sciences that we get in 2 years of college now, or 3 years of college, and learn enough of the things that we learn as medical students by simple biochemical reactions, the nature of cellular metabolism, the Krebs cycle, things like that, that you have to know to get into medical school, but you don't really need to know if you're in the middle of a community, working on patients who are acutely ill. Those things are important as background, but they shouldn't keep people out of practicing. You could pick up those things, and then let's say you're a certified operating room technician in the Army, and you were scrubbing in cases and helping people on the battlefield even, and you haven't been to college, and you get out of that, and you get some of those skills certified and count them towards admission to a training program that would bypass medical school and get trained to do skills now reserved only for MDs. It would be a new way of thinking about training healthcare workers in whole, rather than just a compartmentalized way of training. And I'm not looking to change things drastically all at once. Our best laid plans have the practice of going awry, and there's many things you could be wrong about, or bad things could occur. I would like to see change very gradually. I don't think the medical profession should do anything differently in the way they train, other than letting other people train they want to. And I think over a period of years, it would shortly occur of what we should do differently to improve our models, to work with other people, to work with people who can compete with us, to allow us all to improve our processes. And if you do this gradually, it will come from the ground up. So you could get a Army medic or an operating room technician who someday, without going to college, but with, say, 6 or 8 years of additional training, or 10 years maybe at the most, they could become a surgeon. They could become a great surgeon. That could happen. And that's where they could be working while they're getting those fundamental skills And that's where they could overcome the barrier of not going to college or having to get out of the country to get trained to do things that they could be trained otherwise to do. That's where I think it needs to be concentrated. If you're going to improve the education of disadvantaged, you don't want to start in medical school. You want to go to their elementary schools. You want to improve that education. You want to have job searches in high school. And you want to have people in that school look up to other people in their community who made it and who are inspirations for them. They don't have to go to medical school to get it. They can look at people in their own neighborhood who are now working in hospitals, doing things that they would not be allowed to do under the present system.
Thank you. Any other members have questions? Henry, let me just take a brief moment and see if David or Tessa or Eric or Christina have any questions. If not, I'll circle back around.
Madam Chair,
Yes, David.
if I may use up my question. So I have a question for Dr. Feldstein. During your presentation, you mentioned that we need to have more healthcare providers of all types, but you also sort of emphasized that many more from disadvantaged populations. I was wondering if you could sort of elaborate on that and kind of tie that to sort of the, maybe I'm reading things into this, but maybe if it could be tied into the lowering of the disparity of the medical services among pediatric care. I would be interested in hearing your view on that. But if there is no connection, of course, you don't need to arbitrarily make that connection.
Well, let's look at how we have in disadvantaged communities. There are clearly people who are now working, doing things as an assistant in a medical office, who could train up with a few special courses, take didactic training. And let me step back for a minute. I talked a little bit about how pilots train differently than doctors. One of the things they do differently is a systemic thing. They use modules of training and stacked certifications. So you could get a pilot license to do, let's say, instrument rating and do limited commercial piloting using a single engine aircraft. And you could get that training and then work. And then years later, use that certification to scale up and eventually become an airline pilot. In medicine, we have that's called stackable, time variable learning certain models. You have to learn a certain thing before you move on, but once you learn it, you don't lose it. In medicine, we have a system that's called sequential, time certain knowledge variable. You go to school for a certain time. If you pass, you go to the next course. You may not have done well on the test, but you passed. And that's a different kind of training. Now, if you were to apply the kind of training where you have stackable certificates, you could get people in the community, for example, who work with children, teachers, for example, who could get some training in health and in the classroom be able to pick up things that they wouldn't be able to pick up otherwise. And they could take some of these courses at night, take some of the training in hospitals on weekends, get certified to do something simple, like, I don't know, give an audio exam to students in their classes or refer them, because they're there in the community, they're seeing and they're educated. And it's kind of working from the ground up. I can't tell you, it's not like a program where you design it on high and you say, here's what we do to make things better. It's allowing people to make to find the problems and solve them themselves in a way that would be more facilitated than it is today. So I'm sorry, I can't give you an exact program, but I can tell you a process that we'd start to use that might work better.
Thank you.
Sorry, I see Nathan's hand up. You can go ahead, Nathan.
Thank you. I just wanted to respond to one thing that Dr. Feldstein said, which is, could we potentially teach teachers how to give good audiograms, for example? Well, we one of the brand new roles that I just started as the medical director of the hearing part of the sensory screening program for Arizona, and one of the very first things that has been underway is to expand the training of screeners so that we get more standardized and accurate screening. And the ideas were before my time, so I can't take credit for these, but one of the ideas was to say, let's look at different groups of people who can successfully do this. Now, I would not say that, in a weekend course, we could teach someone how to become a pediatric audiologist, not by a long shot, but we can, in an online course, teach someone how to do successful and accurate screening exams. And that is a huge step in widening. If we make that available to more students more conveniently, I didn't talk much about screening after the newborn period, but that is a big part of the program as well as screening during school. And so looking at opportunities to find people and help them become qualified to do that is a really important step. So in that small way, I think that we've been able to begin the process of accomplishing just what he's talking about.
May I add to what Dr. Page just said? So there's a perfectly good example of what reforming the system would be able to do almost automatically, because a screener that is going to be paid, trained the way Dr. Page just said, would now have a financial incentive to go out and look for that kind of training so that he or she could do that. Because that kind of thing multiplied across all needs for kids and adults would be the kind of thing that people could start to make an income from. And I can't think of a greater incentive to have people do things that are needed than to pay them for it.
Christina, you had a question?
Yes, thank you. So my question is for Dr. Page, and if I heard you right toward the end of your presentation, I think you said that Arizona's loss to follow-up rate is 50%. Is that correct?
Yeah. Go ahead.
Oh,
sorry, go ahead.
I was just going to say that now I am not an expert at all with this data, but we learned a little bit about Eddie from Amanda Hagerman when she gave her presentation last time. And that just seems really, really high to me. And so I'm curious if that's common amongst the states, or if that's unique to Arizona, and if you have any insight into that, because when you said 50%, my ears just picked up on that.
Yeah, you're correct to be having your ears pick up. So now I want to make it clear, that's not the failure to screen. We're still screening 98% of kids. But once we take that group and say, okay, how do we follow up on these kids that were screened but failed? And how do we make sure that they progress through the next phases, get their diagnostic testing? That's where we start. That's the denominator for that number. So for Arizona, the denominator for that group is going to be around 1,500 to 1,700 kids is the group that we're trying to follow up on and get them back in. And in that rate was down to something like 20% a few years ago, pre-pandemic. It dropped considerably, and that was in large part because there was a dedicated follow-up program. That is, there was a group that was contracted with the state to reach out to every single one of those families. And so they did. They made multiple phone calls till they were able to reach families. And there's a group of those families that are never coming in. And they just say, no, I'm not going to bring my kid for a test. I'm not going to do it. I don't think it's important and I don't want to. And we miss those. But just by following up on those and saying, hey, we noticed your kid failed their hearing test, many families were not aware or didn't understand. So much happened in that hospital phase that one piece of paper that said you failed your hearing test just didn't register with them. So one of my roles as the Eddie champion for the AAP is to go to the pediatricians and say, hey, let's make sure you're following up on that, because you do receive that data from the state as well, saying, hey, your patient failed their hearing screen, please make sure they come back. And so with dedicated effort, that number can come down, but it has increased as there is currently no follow-up program established to reach out to those families and try to get them back in. So that 50% is I don't want to say it's exactly 50%, but it's close to 50%, and it is a concerning number.
I have a follow-up question based on Christina's question. I was also curious about the lost to follow-up number. In particular, I was wondering, does that number come from families who have not followed up, or from the state that has not followed up with the families?
Ooh, that's a challenging question to answer. The number indicates any child who disappeared from that process without achieving one of the goals. Either they passed their screen, or they went to diagnostic and had normal hearing. Somewhere they disappeared. Either they failed one step, or they just no longer came through any of the steps. Those are the lost to follow-up group. And so your question is not really one of the numbers, it's really one of the responsibilities, I think. So who should be following up? And probably the answer is both. Parents have a responsibility to their child to follow up on their testing and make sure that things are checked out. But we do feel that as a state, that we also have a responsibility to reach out to them, to help them understand. I mean, some of those families just don't really know what that even means. And I've had very educated parents in my office who've said, yeah, we know we failed, but he seems okay. So we're just going to wait it out and see what happens. And that's really a terrible plan. And these are people who've done their research and are educated and are intelligent, but they don't recognize the risk. And I think some of this is a broader issue of how people don't understand risk. Most of the time, if you leave your kid alone, they're probably going to be okay. Most of the time, if you don't wear your seatbelt in your car, you're probably going to be okay. But on those occasions that you're not, the consequences can be dire. And that's what we see is family says, we're just going to wait this one out. And 3 years later, you got a kid who's not talking. You find out they have significant hearing loss. And now we're up a creek. It's very difficult to manage that at that level without the intervention that could have been performed earlier. So that was a long-winded answer, but I think the answer to your question really is both. I think it's a problem with families not following up. It's a problem with the state not following up.
I have two follow-up questions to that, and then I will allow everyone else to step back in. One, joking aside, is there a mechanism by which parents of infants can get something akin, this is really going to sound silly, but I don't mean this in jest, something akin to what you get when you bring your car in for service. This is the green area, this is the yellow area, this is the red area. You have to act on the red area. The yellow
Yes.
area, you can wait a little bit, but just because parents of new infants are likely very, very overwhelmed by a lot.
Yeah,
Is there anything like that?
there is. And this is actually a challenging scenario. And the reason is that if that child fails their newborn screen, or even more, if that child has a diagnostic test and is shown to have hearing loss, they can be overwhelmed by how much information they get. And so in an attempt to solve the exact problem that you bring up, which is this misunderstanding of the scenario, parents have said that they just felt absolutely deluged by information. And they're getting phone calls from the Parent Advocacy Network. They're getting phone calls from the state, the Schools for the Deaf and Blind. They are, and so then they don't know, who are these people and why did they want to come to my house and what is all this going on? I just have this new baby and I'm trying to figure out how to manage that. And so I think every state is trying to find a balance between overwhelming them with too much information and failing to serve their needs. And there isn't a one-size-fits-all answer. Some parents need and want every bit of information they can get, and they just absorb it. And some parents need the green, yellow, red version to say, hey, your kid got a red, they need follow-up. Here's the appointment. We're going to make sure it happens for you. Simplifying things like that, for example, setting up systems to have those kids follow up from their failed inpatient screen made it significantly more likely that they would come to their outpatient screen. One of the issues, this has been done, I know in Ohio, because we have a leader here who came from Ohio, is that it requires a doctor's order to obtain that follow-up hearing screen. Even though we're mandating it as a state, it can't happen without a doctor's order. And so that patient now has an additional step. They need to go to their pediatrician, get an order, and then go to the follow-up visit. Well, if we can get through that process without that extra step, then they can have, here's your appointment before they leave the hospital from birth. And all they get is a card that says, show up at this location on this date to get your hearing tested. And that has been successful, but it has required circumventing some of the rules that that were created for a purpose, but don't continue to serve everyone well.
And my second follow-up was, you see these mobile mammogram, mobile prostate cancer, mobile blood donation units, right? That go out in the community for people who are busy working, handling childcare, juggling a variety of things, potentially juggling multiple jobs. Is there anything akin to that for pediatric access, especially in the areas that you're referencing?
Not that I am aware of in Arizona right now. It is amenable to that, at least at a screening level. I think at a diagnostic audiology level, you need some heavier equipment and more technology to do that. But even some of that can be done. I know from doing some mission work in Africa that there is a lot of progress that's been made with hearing testing technology that can be done on a tablet. So is it as good as being in an audiology booth? No. But is it better than having nothing? By a long shot. And so you can identify children with hearing loss with some pretty simple and portable technology. So that's a great example of a way to take that to more people. I think the real question would be, where are the people that we need to take it to? And that's what I feel lacking with what I was able to produce today. You know, I would think that kids in Paradise Valley are less likely to not follow up than kids in Guadalupe, for example. And so I'd take that truck to Guadalupe to go test, but I don't actually know if that's true because we haven't been able to take that data down to the granular level to be able to identify where those pockets are. But I love that idea. That would be, if we could produce data to show us that we know where the action needs to be, we could take the service to the people.
Henry, you had your hand up earlier. I don't know if I've asked your question, but go ahead.
No, my Rothbardian inner child really wants to have a in-depth conversation with Dr. Feldstein. So maybe I'll just call you later if you don't mind, Dr. Feldstein.
Mr. Whitner, I gave my email. It's mfeldstein@goldwaterinstitute.org. And I'll show that slide again, but that's what it is. And I'm more than happy to talk to you.
Thank you.
I'm retired. I'm gainfully unemployed.
Do any other members have any questions for our speakers today? Yeah, see some head shakes. Okay, well, you are welcome to stick around. These is our final questions. I know we have a time for public comment, but I do not see any members of the public on our meeting today. Kayla, Angelica, am I correct?
You are correct.
Okay.
Yeah.
Okay, then we will blow by the public comment time. I guess if there's no public comments and no additional questions, Dr. Page and Dr. Feldstein, you're welcome to stay while we go through our standard business, but I imagine you have other important things to attend to besides hanging out with us all day today. So you are certainly permitted to leave and move on to the rest of your day and enjoy your Friday and your weekend.
Thank you very much. Thanks for allowing me to speak.
Thank you for your
Thank
time.
you. Thank you very much.
Okay. That was back to our little group. Our speakers have just been phenomenal. It's so insightful. I mean, just hearing the various things that are at play that can cause some of the disparities. It's been very, very interesting.
Hey, Leslie,
Yeah.
two things.
Yeah.
Do we still have a quorum? It looks like we.
Yes. 1,
scheduled-
2, 3, 4, 5, 6. Yep.
Okay. cool.
Yeah. We've lost some of our members along the way. For people had other things that they had to attend to, but we still have a quorum, so we are still good to go.
The other thing is,
Checking
if
that.
the federal government shuts down, do we still not get paid for this?
All right.
Okay, let's see, where are we? So that concludes our briefing portion, and now we're going to move on to, I guess, approval of the minutes from our July 7th meeting. Kayla, can you bring that up for us?
Sure. Give me 1 second.
Okay. While you're doing that, Kayla, if there is a shutdown, will it impact our ability to do further briefing?
Yes and no. It's good that this briefing took place right before. And as long as you know, our very much higher ups get their act together, then we should be continuing with business as per usual, hopefully not, you know, more than a few weeks. I mean, hopefully not more than a few days, but it shouldn't impact the work of this committee at all. We can, you know, once I return back from being furloughed, I would just move forward with invitations. Yeah.
So Kayla, on that note, do you know like a schedule for that? Because on the court side, we're getting messages that if this goes for 3 weeks or longer, they're going to start suspending jury trials for defendants. So do you know, like, is there, if we're in for 4 weeks, then this is just shut down, support staff's not going to be contactable, just, you know, wait to hear from you?
Yeah. I'm not sure, honestly. I'm definitely gonna keep you all up to date. Like, we still have we can still go on our laptops and check our emails and update committees if necessary. So, but I have no inclination of how long this will be and what will happen in the long term. But crossing my fingers that doesn't happen, it won't become a reality. But sorry, I'm not sure if that answered your question either.
So it looks like you have our meeting minutes up. Kayla, I'll be honest, for me, it's really hard to see. I don't know about for everyone else. I see that whole window. Can you see, just make it. Okay.
Leslie, they were attached to the
Yeah,
meeting
that might
invite
be
as
the
well.
easiest way to go, is for everyone to just look at that. Take a look. It's got a lot of content in there. Let me know if we have a motion to approve.
Leslie, I've looked at them and I move that we approve the minutes.
I'll second. Great, thank you. That was nice and easy. It actually took me longer to talk about getting that up on our screen. Okay, well, thank you guys. Let me see. Okay, then now we just want to discuss the remainder of our group 2 panelists.
Sorry,
Can you bring those names up?
Sure.
I think if I recall, last time we went through several panelists and approved them. Do we have, I want to make sure that we give you a good block of people so that
Yeah.
so that in case the government does not shut down, or alternatively, so that if the government does shut down, we have a good group of people that are already somewhat in the works.
Sure. And sorry, before I forget, it should be relatively quick, but a quick vote for the minutes. I think we
Oh,
did.
thank you. I appreciate that. Everyone who votes to approve the minutes, say aye.
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 All opposed, say nay. Okay, it's unanimous. Thanks for that reminder.
Okay, and you should be able to see my the panelist recommendations board. Let me know if I need to do anything else. I don't know if I can zoom in.
Wait, who in this group?
Are we
Yes,
doing
sir.
another group 2 or are we looking at group 3 now?
I think we're still in group 2.
Think if I could just add a short blurb from last time. I think there was discussion about there were so many people in group 2 that we didn't even discuss the last half of the potential panelists. So I think, yeah, I would agree. We should still be on group 2, but that's totally up to you guys.
I really want to hear from some people from Indian Health Services. Like, they're on the front line. They know the problem. Like, that would be perfect for me.
I do too. Are we still in the advocacy and, okay, we're not yet to the government. I
No,
like hearing from someone from PCH. I think that's really helpful.
Have any of these people been approved yet, other than the 3 we heard today?
yes. So we had a list of approved panelists for today. Only 3 were confirmed, and these others were unavailable. I should just put that up.
So all these, they've all been approved?
The ones with the green right here have been.
Oh, I see.
And-
Yeah, everyone else has not been approved as a panelist by the committee.
And then not available was just not available for today.
Yes.
Okay.
Yep, because a lot of these, I think almost all, if not, yeah, no, I think almost all of them would have been interested, but they just had scheduling conflicts.
Can you remind us, Dr. Christensen? It looks like
Mhm.
Dr. Christensen wasn't yet approved, but was not available.
She was actually not on the list last time we met. I've reached out to Dixie Gaikowski from IHS, and she actually referred me to Dr. Christensen to speak instead. And so my plan at the time was to get the group's approval like right before the briefing. That never really, she couldn't make it today anyway. So my suggestion would be to maybe approve her for the next panel, especially because, as Henry mentioned, that is a community that this committee is interested in hearing from.
So I would actually like to hear from both Christensen and Gaikowski. I know Gaikowski defers to the MD, but she's the administrator for the Tucson area. And sometimes you learn, like in the legal system, more talking to the court administrator than the presiding judge. So we could get both of them. That'd be fantastic. So I guess I move to approve Christensen as
Well. Okay, yeah.
I second. All in favor, say aye.
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 Any opposed, say nay. All right, unanimous.
Leslie, did we ever put Julie Baldwin or anybody from the Center for Health Equity Research on the list? I don't see them on there, but I don't know if it's because nobody responded or we couldn't. I can't remember if that was this panel discussion or the last one, Kayla, that we had Julie on there.
I don't recall, and
I don't
unfortunately,
either.
I'm not able to get into Monday.com right
Yeah,
now.
she's not on there now, but I don't know if it was because we just never got a response from her. But I sent Leslie and Kayla an email. The president at NAU just announced that we're going to have a new medical college at NAU, which is focused on rural health and community-focused healthcare, which is super interesting that the Board of Regents approved that, which is cool. And the new vice president that's going to oversee all this is a lady named Julie Baldwin, a Dr. Julie Baldwin, who has a PhD in public health, and she's been the director of the Center for Health Equity Research, which focuses on kind of disparities in healthcare. And so I imagine I probably brought her up as a potential academic, but now that she's going to be the new vice president and kind of overseeing this new College of Health and some restructuring in our nursing school is becoming a college of nursing as well as part of this whole rural healthcare focus up here at NAU. This just came out this morning, or I just shared it earlier. She may have more, I don't know, I think availability is the right word, interest or incentive to speak to us. So I might add her on there just to see. I sent her a note today to say, hey, congratulations, after the announcement came out, and said, I'm working on this thing with the USCCR Arizona Advisory Committee, and thought she'd want to know. And she's apparently out of the office until around the 10th of October. But if she gets back to me, I'll let people know. But yeah, she'd be a good one to add probably.
Yeah, I feel like she'd be a great one to add. I wonder if she was in a prior version of the panelist recommendations and somehow never made it to this. Remember, we had those two lists.
Yeah, I'm guessing that I would have put her on the list for academics because she's like a department chair, but now that she's going to be administering this entire initiative, she might be a good one for the policy and governance or advocates and community, either one of those. So I'll try to chase her down and see if she's willing to do it.
Okay.
That seems like a theme
So-
that underserved communities, the rural healthcare issue without access to practitioners. That seems to be a theme in our speakers. I move to approve
Second,
Julie Baldwin.
I
Great.
second.
All approve, all in favor, say aye.
Aye.
Any opposed, say nay. All
And
right,
she may have somebody else that she would want to send, but she would be the person I'm going to contact.
yeah, it seems like maybe she might not have a lot of time on her hands at the moment. Let me ask this, looking at this list, maybe we can do this kind of in a more summary fashion. Is there anyone that's currently on the list that we would not approve? Because if we give Kayla the opportunity to reach out to more people, then we have a better chance of getting the information that we need to finalize our report. What do you think of tackling it that way?
When you say not approve, is there
Well,
limit?
no, my hope was to maybe just approve the rest of this group to list kind of in a summary fashion to give Kayla that opportunity to have some leeway that she can reach out to all of those individuals and kind of pull individuals and get us scheduled for some other sessions.
Can I ask, maybe this is a question you can't answer, but is there any notion of how many hearings we're gonna have? Or, for example, we haven't gotten to group 3. For group 2, are we just gonna have hearings until we run out of approved witnesses who are available?
That's a very good question. I guess that's for the group to decide. We have hearings until we're sick of having hearings, or, I mean, eventually, I am somebody who I will get as much information as possible. But I am already seeing a theme in the information we've received. I do think, like Henry said, that having someone from IHS is very important. I think Julie is going to give us some of that information, maybe on some of these. Like I can see this medically underserved areas report from the Department of Health Services that's referenced in that AZ Central article. Maybe she can give us some information there. What do you think? Maybe one more? We'll approve everyone, see who we can get in that last kind of group 2 briefing, and then we'll move on to the government people.
I would agree with that.
Are we limited to 3 speakers per hearing?
No, not necessarily. I think it's been 3 for this briefing as well as the last, just as a coincidence. But we aim to have around 3 to 4, 3 to 5, depending on the content of what the speakers are presenting on.
I think it also,
One problem is you don't really know how useful it's going to be until you hear them. For example, we've now heard 6. I thought the 2 from the Goldwater Institute were very interesting and very knowledgeable, but they really didn't have much specific to what we're talking about. And I don't know how much we would use what they said in a report.
I think the speaker today, Dr. Feldstein, he talked about similar things that we had heard our prior speakers discuss, and that was if you have the disparities in the medical profession itself, then you have the potential for disparities in the care and access to care. And his arguments about being more expansive in the medical profession, to me, seem to resolve one of the concerns that the doctor from PCH noted, which was you don't have practitioners in these medically underserved areas, and so there's not follow-up. So it seems, I feel, respectfully, I disagree. I think that what the Goldwater Institute presenters have said have been helpful. They have neither one was right with what I anticipated in going into this report, but both I think have given me some clarity with regard to how some of those disparities exist on a more systemic level.
Yeah, I just don't know to what extent that affects the jurisdiction or interest of the U.S. Civil Rights Commission, which is who we're, I mean, it would be different if we were filing a report to the Arizona legislature or Congress because many of the things he talks about deal with statutes and regulations of licensing boards. I mean, this is something I spent a lot of time on, and I agree with everything he said, but I don't know how much of that is in the scope of jurisdiction of the U.S. Civil Rights Commission.
So, I mean, I will, Jonathan, I totally agree with you. I thought abolishing the AMA was, I like the idea, but I don't think we have the chutzpah or the juice to get that through. But I gotta say, his suggestion about why can't pharmacists administer pediatric, injections, that hit home extremely hard to me, because I just took my 1-year-old daughter to get her COVID booster and all that stuff. And you wait in the pediatrician's lobby, and then you go back there and they come in for 5 seconds and send an assistant in to do it anyway. So, why can't I just go to Costco while I'm there and, get my 20 pounds of chicken wings and my baby's pediatric shots at the same time. To me, that's a concrete, actual idea that I'm kind of jazzed about.
Yeah, I don't disagree with that, Henry. And I've made similar recommendations regarding the legal profession, because there are lots of people who are competent to do things they're barred from doing. I just don't know if that's relevant to the U.S. Civil Rights Commission, whether they have any interest or jurisdiction to deal with these which are mostly state, not federal. That's my only point.
Yeah, that's a good point.
Right.
That's
I mean,
fair.
at what point do we start recommending statutes that are going to start violating the anti-commandeering doctrine or whatnot? Yeah, I get it. Yeah.
But I think to add, even though our reports are, our audience, quote unquote, is the commissioners of our agency. I mean, part of their job is supposed to forward the recommendations to the state the interested parties, so stakeholders, legislators, who could make those changes on a local level. And then also, we haven't gotten there yet, but once we complete a report, there's also a post-report stage that we're kind of implementing now, where we create these one to 2 page policy briefs that the committee comes up with and can give like legislators, and they'll have like a fact sheet, like really quick recommendations for what the committee suggests based on the report that you wrote. So even though like our main audience is the commission, I do think that there's like a lot of opportunity to reach out to like people on a local level to change local legislation. So just wanted to add that in there.
Maybe we ask the commission to adopt Matt Jewett's suggestion. We just make Medicaid a lot less confusing.
Yeah. I think.
Nice.
Hey, Leslie, I just got an email back from Julie, and she said, hey, thanks for your note. I'd love to talk more about this. Can we meet mid to late October? She's traveling most of October, and the position doesn't really officially start till January. And so I responded and said, we'd love to. I'm in this meeting and people are excited to hear from you, both from the Center for Health Equity Research history, as well as kind of the plans for this new college. And so I'll let you all know when she gets back into town, and I'll plan on sitting down with her and having coffee at Starbucks or something and chatting. And I think she'll probably be on board with testifying if the schedule works out for her.
Great. Wonderful. Thank you. That was
Sure.
so efficient.
So to that end, can I propose that our last meeting for category or group 2 be the 2 people from Indian Health Services and Julie Baldwin, because I think they'll dovetail very nicely. And then we can move on to group 3.
Yeah, Kayla, and did you speak with anyone in group 2 outside of those 3 individuals that you think, based on your discussions with them, we should really speak with them? They're going to bring something new to the table that we haven't already covered.
No, I just wanted to ask though, is there any interest in like hearing from like I think a lot of our presenters have been more research based and like data driven. Although I know that Dr. Fellman was a health, pediatrician. Any other pediatricians, like healthcare providers who directly like work with impacted communities? Leslie, you did send me that article about, and if anyone's interested in looking at it, the DCS case where the child kept being, inadvertently like reported to DCS while trying to receive care and MRIs. And so this pediatrician was cited as their doctor who kind of advocated for the family, like she just needs care. She's not being abused, like she just needs care. So someone like that, I obviously just have his name because of the article. I'm sure there's plenty of other pediatricians I could reach out to, but that's just a starting point for me. I don't know if the group is interested in hearing from other healthcare providers.
I don't know. I mean, for me, if we talk to individual physicians about individual cases, we run the risk of being too anecdotal about those particular cases versus systemic. And if we talk
Sure.
systemic change, I don't know.
Well, one thing I think is interesting about Dr. Wooten is one, the area he works in seems to be, it's in Phoenix, so it's an urban area, which I think looks actually in the address looks maybe lower socioeconomic strata. Also, his history, interesting, is that he was the first African-American in 8 years to go to the U of A School of Medicine. He's one of the youngest physicians in Arizona ever. So, he kind of ties a little bit into some of those other notions that we've heard from other speakers, which is we have more diversity in practitioners, we have more access to care in communities. So maybe I agree with you, Henry, like we're not going to each practitioner out there in the world. One, that would take far too long. In this, he's got a kind of unique perspective. He's not going to be able to talk directly to the care. He's going to be barred by HIPAA anyway, but he can talk in generalities about what he's experienced, maybe with this family, but more importantly, with maybe others that he works with who are less inclined to seek medical care because they're worried about DCS involvement.
Sure. I'm wondering now, though, everyone we've heard from, are they either based in Tucson or Phoenix?
I don't know the answer to that. I also realize that a group that we haven't heard of at all is like some of the nonprofits that serve some of these communities day in and day out. We haven't heard from them. Children's Action Alliance is more like a policy group. But what about the groups that like serve, I don't know, domestic violence victims? There are shelters, like some like Lutheran Social Services, Catholic Charities, some of the groups that coordinate some social services and healthcare. Just kind of brainstorming with the idea that we might have just one more briefing on the group too.
I would like to hear from someone in that area. I think that would be really helpful, and maybe even more helpful than hearing from another practitioner.
I'm
just wondering, because you mentioned domestic violence shelters and things like that, and having done work in that field through the criminal side, it seems that their immediate focus when they respond to domestic violence crises is removal and basic needs as opposed to medical care. That's just been my experience with that.
Yeah.
They need to go to a shelter, they need to get clothing, food, be able to go to work and things like that. So I don't know if they're going to be dovetailed to medical treatment as much as we want them to.
Well, I guess, Leslie, maybe my suggestion would be to approve the individuals, prioritize the individuals from IHS as well as Julie Baldwin, and then, fill in as necessary from the rest of group 2, or even the people who were invited the first round, but just couldn't make it to today's briefing. Like someone like Dr. Donald Warren. I know that he was fairly interested in speaking. He's just very busy, but he's from the Center for Indigenous Health. And then maybe focusing on those like nonprofit groups, or I can brainstorm. I think I haven't had time necessarily to brainstorm some of your creative like suggestions of like how to reach impacted individuals, or like, you know, parent support groups for like kids who are, you know, as it relates to Eddie, you know, parents of children who have hearing loss, and like, I'm sure they have some sort of groups out there. So just maybe focusing on that as like the follow-up, as like the impacted individual briefing or public forum where they could come and talk.
Well, and maybe talking, you know, at least having you reach out to
Yeah.
Dr. Wooten, even if
Mhm.
he doesn't come in and speak as part of this group
Yeah,
too.
yeah. Yeah, and that's, you know, that's a good point. I can always just say, if they're not selected as a panelist, there's moments for public comment after each briefing. So
Well, for these people that can't actually show up to testify, can we also accept written
yeah,
affidavits or whatnot from them?
yeah. I'll reach out to pretty much everyone who's been quote unquote approved as panelists in the past and ask if they would like to submit written testimony.
I guess with that, I'd move to approve the remainder of the people on group 2.
I second that.
Great. All in agreement, say aye.
Aye.
Any
Aye.
opposed, say nay. Okay, unanimous. Hey, Henry, I think you were just volunteered and you didn't even know it. If we're allowed to do a questionnaire to the public, can we do something like that? Stop getting so small and moving away from the screen. Kayla, are we allowed to have just a questionnaire so that if practitioners or members of the public who might not be able to come to us, like, so they don't have to maybe write up a whole attestation or something, but can just answer a few pointed questions?
Yeah, and so that's actually something that I might have mentioned in a prep meeting with you, Leslie, is that, and I guess I am announcing it too to the committee right now, is that we are working on sort of like each state has their own kind of webpage, homepage, where members of the public who are interested in generally civil rights can visit, but you know, if potential panelists or whatever topic you choose, people who are impacted by that topic can come in. It'll be a projects page, so it'll be, you know, racial and ethnic disparities in pediatric healthcare page. And part of that, I have some ideas about putting a survey monkey, like questionnaire, as you're mentioning, because you did mention like there are some barriers to getting on Zoom during a work day. Like not everyone can do that.
Right.
And so I do think that's a great idea. I think we have, as a unit, have spoken about like the limitations on sending out surveys, but this way, if it's like on a page, I'm not sure if that, you know, their law is gray. So is that okay? We have to figure that out. And I hope it is. And I think that would be one way to address, you know, what you're suggesting.
So, I mean, to that point, I'd be more than happy to write up a couple concrete, like maybe too concrete. I don't know, like what are some specific federal statutes that have, or reporting requirements that have affected your practice or something like that. I don't know.
Or I was thinking even if it was for the public generally, what are some barriers that prevent you from getting healthcare for your children?
Yeah,
You know,
that'd be great. So I'm hoping to talk to my boss about that, actually,
Okay.
putting that as an option for the project pages in the future.
that might be a good and kind of efficient way to gather info.
Yeah, absolutely.
Okay. All right. So we have we've approved everyone in 2. Kayla's going to look into the survey. Henry's going to write all the questions. Okay, let's see what's next on our agenda. Can we schedule the next meeting? Is that next?
To clarify, I assume that the next time we meet will be for the next briefing. Is that okay? And if that's the case, then I'll ask Angelica to send out a scheduling survey.
Okay.
Again, hopefully when the government reopens, to you all to schedule that.
Okay. Perfect. And with that, is there anything left on our agenda?
I don't think so.
Fantastic, everyone. It's Friday. It's 1:48. Live it up, or at least get back to your work for the rest of the day. Okay, do we have to move to end to adjourn?
Sure.
What
Sure.
do we do? I can.
I don't know if it's necessarily required, but I think we have.
I'll
been.
move to adjourn.
Okay, thanks, Rebecca.
Second.
Yeah, thank you, Henry. All approve? Say aye.
Aye.
Yeah, aye. Does anyone want to stay in chat? Say nay. All right, everybody, have a wonderful weekend.
Thank you.
Thanks, you
Thank you.
too.
Well, thank you.